and we just got connection to Hamburg for the live case. They are supposed to be ready at 3 o'clock, so we will start the presentations first and then go over to the peripheral live case. So during the meeting I already mentioned, we had about almost 1,800 members attending the meeting. The guideline sessions are traditionally a very central part of this meeting, and the main lecture auditoriums were packed with people listening here, and we are very proud and happy to present these guidelines here. These are my disclosures concerning this talk. Well, as I already mentioned, this is the first guideline on this topic which is ever published. The writing group started its work in June 2018 and finally ended their work just before the annual meeting. 18 reviewers reviewed this guideline in several rounds, and the methodology of this guideline is in accordance to the general methodology of ESVS guidelines. So after the first kick-off meeting, we performed systematic review, including more than 6,500 abstracts. Then we had another second meeting in January 2019, and all the further work was done by each member of the writing committee, including a couple of telephone conferences. And the final document finally was submitted end of July, and this guideline will be published online in January or February 2020. First of all, I would like to go over initial management and decision making. The optimal management of acute limb ischemia is prompt diagnosis, and also associated here the exact assessment of severity of the disease and the degree of threatening for the affected limb. The treatment should be done in the right place, and the affected patients should be treated by a specialist with access to all treatment options. The severity of acute limb ischemia is classified according to the Rutherford classification for acute limb ischemia, and we were agreed that Rutherford stage 2B is suggested a surgical emergency, so needing emergent and acute treatment. This came to the following recommendations: that patients diagnosed with acute limb ischemia in a non-vascular center should be transferred to a vascular center that offers the full range of open and endo treatment with an urgency that depends on the severity of ischemia, a class 1 level B recommendation. And in addition to this, the center should have access in a hybrid theater or an operative theater with a C-arm equipment, and by a clinical team able to offer the entire range of open and endovascular techniques in a single procedure. Heparin also is recommended as a first-line treatment for patients awaiting the revascularization. Oxygen should be applied, and analgesia adequately and intravenous rehydration also should be applied to the patient. And finally, for patients with ALI treated by open surgery, prostacyclin as analogous may be considered during and after revascularization, a class 2B recommendation, because there is scarce evidence on this specific subgroup of patients. The question also is local or general anesthesia, and we recommended that patients requiring thromboembolectomy for ALI, regional or local anesthesia may be considered, but always with an anesthesiologist being present in the operation room. This is caused to the fact that the treatment modalities often vary during the procedure, and sometimes we need an escalation of our initial indication for surgery or intervention. But even though we have a still ongoing high morbidity and mortality of embolic acute limb ischemia, as shown in this contemporary series of 170 patients. In addition to this, the use of over-the-wire embolectomy catheters under fluoroscopic control should be considered a class 2A level C recommendation. For patients requiring an intrainguinal bypass procedure for ALI, the preferential use of a vein graft should be considered. This was also recommended in a 2A level C classification because there is so scarce evidence for this specific subset of patients, although we know that the outcomes of patients with acute limb ischemia compared to chronic limb ischemia is really worse. Here we see that the overall one-year results after ALI results in a major amputation rate of 22.4% versus 9.7% in the chronic phase, death 20% compared to 13% in the chronic limb ischemic patient, and amputation-free survival 62 versus 77%. We put a focus on completion control in these patients, since there very often is residual thrombus in the vessels treated, and the identification is very much associated with reduced risk of reintervention and limb loss. And although no control trials exist and the benefit of limb salvage finally remains unclear, we recommended local thrombolysis in these patients since severe bleeding complications are very rare in these conditions. For patients with ALI caused by graft occlusion, identification and treatment of the cause of graft occlusion is recommended because it's often due to progression of atherosclerosis proximal or distal to the graft or even within the graft, and intima hyperplasia often plays a major role. There are no comparative studies having specifically addressed the optimal treatment here, but this very often leads to an extension of therapy. Although thrombectomy or bypass still play the major role in ALI, there is a trend to have multi-level occlusive disease, and they may best be treated with a combination of open and endovascular treatment. So this is the reason why we suggest that there should be a clinical team able to offer the entire range of open and endo treatment options during a single procedure. A current recommendation supporting this was this paper including 300 patients with ALI of the lower leg, showing that intraoperative angiography after embolectomy revealed a higher rate of intraoperative reinterventions, a higher rate of additional interventions due to residual stenosis and occlusion, and after all, a lower rate of re-occlusions after 24 months. We also recommended antithrombotic strategies, including heparin, anticoagulants, and also antithrombotic agents. And one of the major studies supporting this recommendation was the recently published COMPLAS study, which had a subgroup of patients with acute limb events, showing that the combination of low-dose rivaroxaban plus ASS 100 milligrams per day really led to a benefit in terms of amputation-free survival and survival overall. So we finally ended up with this recommendation here that antiplatelet therapy or anticoagulation and statins are recommended long-term to reduce cardiovascular events following acute limb ischemia revascularization. We also included the upper limb. Although this entity is completely different, it's more likely to be embolic and it's less likely to be immediately limb and life-threatening. And since conservative treatment versus surgical treatment often doesn't really show a good outcome here, we recommended that patients with acute limb ischemia of the upper limb, conservative treatment with anticoagulation alone is not recommended if the arm is threatened or if limb function is important to quality of life. In other less severe acute cases, a pure conservative treatment options may be reasonable, however. Emergency 4-compartment fasciotomy was also recommended in this guideline with a high class of evidence. And when post-ischemic compartment syndrome is diagnosed, rapid fasciotomy within 2 hours should be performed. Prophylactic 4-compartment fasciotomy should be considered if ischemia before revascularization has been profound or prolonged, and then we even would recommend to start with fasciotomy before proceeding with the revascularization. However, a pure prophylactic compartment fasciotomy is not recommended in every cases. Thank you very much for your attention concerning this